Hi, everyone. Thank you for attending our second SOF Health Team Room Deep Dive, which is a follow-on event from our May SOF Team Room that we hosted in collaboration with the Global SOF Foundation. My name is Kaylee Lehman, and I lead the Military Special Operations Family Collaborative, which is a nonprofit public health initiative for the special operations community. This Health Deep Dive is a follow-on event from the legacy conversation that took place last month where we tackled transition issues. This follow-on conversation covers the effects of high allostatic load, often referred to as operator syndrome in our special operations community. The SOF Team Room starts a conversation, but there's way too much to cover in a 2-hour event. So our health sprints take on health interventions that are often not yet endorsed or evidence-based. Last month, we took on operator syndrome and high allostatic load. Those who served or are serving in special operations often have one or more chronic health condition, often tied to high persistent stress and service-related exposures. This can make it really hard to find and access effective care. And this is why we're hosting this deep dive tonight. This event is designed to provide our community with an opportunity to engage experts familiar with health and care of special operations community on high demand health topics. We will start the evening discussing what is known about high allostatic load in special operations, and then our doctors will discuss why it's a tough topic to learn more about and to treat, and how you can seek quality care, why it is important to involve a primary care provider and your own family. Our MSOF team member, Sergeant Major Retired Erick Miyares, will introduce our panel and moderate the question and answer period and a discussion among those attending tonight. Erick's a former Special Mission Unit operator and U.S. Marine. You'll have the opportunity to unmute and ask the doctors questions throughout the evening. Please raise your virtual hand, and if you want to speak, and Erick can call on you. And if you would rather Erick ask your question for you, please just type it in the chat. If the topic has been on your mind for quite a while and you've already submitted questions to our team, we are ready and Erick will be sure to ask them. But if we do run out of time, we will include the responses to unanswered questions that we don't get to in the resources following the event. You'll notice this session is being recorded. You're welcome to keep your camera off to avoid being recorded. Since these are important topics to many in our community, this deep dive will be a resource available following tonight's event. You can be on the lookout for a blog post, the video recordings that'll be emailed, they'll be posted on our YouTube channel, and be available through other means. Operator syndrome, it's a challenging health topic for a lot of reasons. It's also referenced as the natural effect of a high allostatic load or chronic stress. It involves multiple chronic illnesses, and there's little research and common understanding about the effects of high allostatic load. This is especially true in our community, as many of you are probably very familiar. There's even less consensus on the topic for our community, for first responders and the military. But there's a lot to learn, and it's through conversations such as these tonight that we identify what needs to come next and get information into the hands of service members that need it now. So without any further delay for me, Erick, would you please get us started on tonight's topic and begin the conversation?
Absolutely. Hi, everyone. Good evening. All right, so I'm honored to introduce tonight's panel of experts, Dr. Frueh, Dr. James Fowler, and Dr. Bryan Stepanenko. Dr. Chris Frueh is a frequent guest at SOF events. He is a tireless advocate of SOF health and well-being, and the lead author of the paper that coined the term operator syndrome. Dr. Fowler is a co-author of the operator syndrome paper and professor of psychology, conducting research into innovative treatment options for SOF veterans and caregiver brain health. Dr. Bryan Stepanenko is an Army family physician involved with the care of Army Special Operations Forces and an advocate for a whole person-oriented functional medicine approach to treating complex health issues. These experts are here to help all of us unpack what we know about operator syndrome. Operator syndrome is a term used to describe the way a high allostatic load seems to impact service members in our community. We will start the night with each doctor giving a brief introduction of themselves, their work, and exposure to operator syndrome. Then following Dr. Stepanenko's brief intro, we will begin the discussions to answer your questions. Dr. Frueh, can you please introduce yourself and how your team came to write that brought this conversation into public? Thank you.
Thank you, Eric. Sure. So my name is Chris Frueh. I'm a clinical psychologist. And I've spent about 30 years now working with veterans, service members, contractors, and in a variety of environments. And about 10 years ago, I started helping out a few of my friends who were, the first friend I was working with was a Navy SEAL. And it was just a question of, well, geez, what can we do for you? And his statement was, I don't know. I don't know what's wrong with me. I just know I'm not the same as I used to be. And so as somebody who spent, at that time, a couple of decades working with veterans with PTSD, I assumed maybe it had something to do with PTSD and maybe it was kind of in that realm. Well, it turned out it really kind of wasn't. And as we started I started going, well, let's just start exploring things. Let's get a blood test. Let's get a sleep study. And as we kind of went through that process and started to find solutions, and he started to feel better and perform better, he started sending some of his friends my way. So through a snowball effect, I started over the course of the last decade, I've talked with many operators and many spouses along the way. And the original draft of the operator syndrome paper was not intended to be a medical paper. It was just an educational document that I drew up to share with my friends and to show them and to kind of have something to kind of guide them and guide some of our discussions. And after several years of using it in that way, along with my colleagues, a group of us, we started to kind of take that document and reshape it, reformulate it, and we put it into the format that it is now when it was published. And I just have to immediately emphasize, I had really good colleagues working with me on the paper, and I had really good colleagues who were kind of educating me. And some of them are here in this room, in the Zoom room here with us tonight. And certainly the other two presenters on the panel are people who really had a profound influence on my thinking. So that's kind of where it comes from, and that's maybe the story. Was there a part two to your question, Eric, or?
No, not at this point. I just wanted to go ahead and give you, let you do your introduction, and then we'll go ahead and Dr. Fowler, and then right after that, Dr. Stepanenko. If you could please kick off with your introductions, we appreciate it.
Sure thing. So, hi, everyone. I'm Chris Fowler. I'm a PhD psychologist as well. Been working with Chris Frueh for about 12 years now. We worked together in a psychiatric hospital in Houston. We knew each other for years back, but my work is really focused on these kind of conditions that have more than one symptom profile, more than one cause, and they'll oftentimes are exacerbated by things that we just have no clue what the initial origin is. So when Chris started talking to me about the Synchrony program, the idea for a program where we could begin to work with these SOF veterans and learn from them, because they are experts by experience, and develop some programs that might be helpful to them and make that a learning system as we go, I became very intrigued. And so I guess I've seen about 8 of the guys that Chris and different foundations, including the Quick Reaction Foundation, was able to help support their treatment at Houston Methodist. And it's been a great journey so far, and we have a lot more to learn, but we'll get to that a bit later.
Excellent. Thank you, Dr. Stepanenko.
All right. Thanks for having me on. So I'm a board certified family medicine physician and Army family med doc, and I've got unconventional training background and perspective on healthcare for the war fighter. And essentially, I've got training and a background in functional medicine, which is really just a framework of care, framework of different way of thinking about the person sitting in front of you to really try to understand this person in context over time and things that have contributed to their root causes of dysfunction. So really trained two brains going through medical school, learning conventional medicine, learning to pass the test, learning to pass the rotation, and practice good medicine from everyone else's perspective. But really what drives me is that the concept that exercise is medicine, lifestyle is medicine, food is medicine, and there's ways to support those foundations of health and well-being that I think we need to start with, and that's where I always try to start with my patients. So generally, anyone functional medicine trained or familiar with that area, it generally aligns with those beliefs. So coming into my Army medical residency training, I was eager to find out how can functional medicine help military healthcare. And I'm a systems-oriented thinker, so I did a site visit over to Cleveland Clinic Center for Functional Medicine. Wanted to figure out, what does right look like in a system that is able to support a functional medicine approach to care. And someone serendipitously put me in touch with Jeff Dardia, who's currently active duty. I'm active duty. We met in 2016, and Master Sergeant Jeff Dardia, he's going to be on the phone call today, but he clarified for me the why I'm here, what I think my life mission and purpose is, because he's essentially a success story for operator syndrome. He broke in every way that you can possibly break, and was motivated to where he was medically separated once from one branch, came back, went Green Beret, and has been Green Beret for a full career ever since. He's a guy that did not accept the answer of here's your ill, here's your pill, and here's your disability. He's a person who became infatuated with what was causing him to break and what was contributing to his dysfunction. He sought out functional medicine care at the Cleveland Clinic Center for Functional Medicine, and Task Force Dagger Foundation and their Pathway to Care has created an opportunity for complex conditions and operators basically to get there and get care and get fixed. So we've been educating together ever since, both healthcare, population, military healthcare system practitioners, and operators in general through some of his efforts on what are root causes of dysfunction, what are military specific operational exposures, and how does what you do, think, and eat matter in your ability to rebuild, recover, repair, and have longevity as an operator. So I've kind of approached this from a different perspective in that we were figuring out how does functional medicine help us understand early patterns of dysfunction before it achieves an end state, which I think we're all talking about and using the term operator syndrome to define. So two biggest things I want to mention right off the bat is that operator syndrome, I think, is an end state, and this term just helps us communicate about that end state and patterns of dysfunction that define it. But the most productive conversation, I think, is going to be had around those contributing factors and how we get to those states of dysfunction. So we're definitely going to touch on that today. And the other thing is that there's a lot more research already out there that's been done about the contributing factors that we're aware of. So I think it's going to be an optimistic conversation today, where we get to hear about the fact that there's already so much that's been done to investigate what contributes to the dysfunction and the dysfunctional patterns, and we can really explore that. I hope for a productive conversation around some of that, of how do we just rethink the information that's available, the research that's already been done, to organize it into a way that we can apply it to operator syndrome to prevent it. Thank you.
No, thank you. I think that was excellent. And it kind of hits the first question, right? You provided a lot of some of the stuff that we're going to have on the chopping block today, and in particular the word, operator syndrome of the term. I mean, I printed it out again before here. I think I read it on my phone, on my tablet, on my computer. I read it on military.com. And so just for reference, I retired in 2020, October, after 20 years, just, being in a special missions unit. Before that, a couple more years in the military. And when I first heard this term, I quickly read it and I said, that's not me. I don't have a syndrome. I'm okay. And so about a year and a half later, I'm still kind of looking at that term going, okay, so some of the points you guys made are what are those factors and which ones do I think I have? And I want to say that that's kind of how many probably family members look at it. Is this what my service member has? And the operator, former or current, looks at it the same. And so with that, I'm going to pose this question that we have is, and it's a few parts. Do we think that there's a better diagnosis than operator syndrome? With the name of operator syndrome, what diagnostic criteria are we using to make this diagnosis? And I'll add a little bit more. Is there a scale or staging criteria in development? And I'll stop there and see which one of you three want to take a bite at that.
I can make a brief comment. So as a diagnosis, it isn't one. And I think we know that, and everybody's been consistent saying, it doesn't have an ICD-10 code, and it isn't clearly defined right now, other than the excellent paper Chris and Dr. Frueh and Dr. Fowler have put forward. So right now, it's a pattern of dysfunction. And that's what all syndromes are. They start up with a syndromic picture. They've laid out criteria for it, and I don't think there's any clear shared understanding as to what percentage of those patterns of dysfunction you need to meet in order for it to apply. But once again, it's communicating an end state, and it's communicating what can happen if all these patterns of dysfunction are in one picture, and how can you then backtrack and look at total exposures or rethink the path that we got there. What was the second part of that question? And Dr. Frueh, Fowler, if you want to jump in.
Sure, I'll chime in. Yeah, agree. I don't think any of us conceived of operator syndrome as a diagnosis per se. It's really a framework, and it's a framework for understanding the patterns of dysfunction and suffering and that are common. And so, I mean, really, if you look at it, if you look at all the different elements of it, what we've been calling operator syndrome is really a collection of well-known, well-understood medical diagnoses for the most part. And except that the idea, I think the concept is it brings them all together, and it speaks to the reality that they're interrelated with each other. So if you're not sleeping well and you have a TBI, that's bad. Your brain isn't going to heal very easily if you're not sleeping well. But if you have a TBI, it makes it harder to sleep. If you have a TBI and you're not sleeping and you're under chronic stress, you may have your testosterone is likely to go down. And when testosterone goes down in a relatively young man, there's a cascade of second and third order effects that come from that. So I think our thinking was trying to just sort of draw attention to the fact that these difficulties all kind of cluster together in people who have gone through some of these same kind of experiences, both training and combat. It's really just a way to get to move the conversation along to help guys get well and help the families understand what's going on and have some solutions.
And some other terminology that we keep hearing is allostasis. And I'm actually excited that term is being used very consistently in this total discussion. But allostatic load, at least from the functional medicine perspective, is a term we use to describe the totality of exposures of burden. And yes, a more formal, maybe medical definition aligns with the psychiatric or stressor burden. However, I think for this conversation, we may need to broaden that understanding of what allostatic load means, because allostatic overload is what happens when your body's not able to get back to homeostasis, when your body's not able to regenerate, repair the way it used to. So allostatic overload is an important term in this discussion. In-service members, I think, is another part that would be helpful for consistent messaging, because it's not just military service members. We are seeing patterns like this in military, non-military, including fire and police officers as well. And there's plenty of others like civil service members that this pattern is pretty consistent with. So not to take it away from any other population, it's just we see patterns of dysfunction like this, and we learn lessons the earliest and the fastest from extremophiles, the people that have the highest rates of total exposure. So I have a framework that we've been using to communicate what contributes to that total allostatic burden. And when we talk about root causes of dysfunction, the question becomes, okay, well, what are the lifestyle factors? What are the exposure factors? And I do want to share with you guys later a framework, but there's an acronym and a mnemonic of all of the contributing factors that you can explore further and look into and say, well, this is relevant to me, this is relevant to me. Maybe I've got some areas of dysfunction, some things going on here, but there's some structured ways of approaching and defining your total allostatic load.
Now, Bryan, that's a great point of sort of defining. You said some key terms. I want to give an opportunity to Dr. Fowler to kind of chip in there, and then I'll follow up with one more question. Dr. Fowler?
Sure. Well, I think we have complete Kappa agreement on it's not the perfect term. We're not at a point yet of being able to identify what is the cut point, what's the threshold for which someone meets the criteria, whatever the multitudes of criteria can be. One thing we know, and I think this is one of the reasons we made this term, was because what it's not. It is not PTSD. Okay? It is not an illness. It is a cluster of symptoms and experiences that lay people low. And at the best cut point we have at this point is when a guy or a woman comes in and says, "I'm not myself. I'm not where I used to be." And they're not talking about, so you got to think about your audience. They're not the people who are going to say, "Well, I'm just a little bit off today, doc. Let me come see you." These are people that wait for a very long time before they say ouch to anything. So, when they know that they're off and they're willing to seek help, when their families know that they're really off, they've seen them through all kinds of things. So this is the best threshold we have at this point. We've got a lot of work to do on that front, but at the moment, it's very pragmatic. It works very well.
If I could just, I realized I didn't address the question about where did the phrase itself come from. And so I'm gonna explain that. And the answer is I don't know. I don't know at what point I started using that internally in my own thoughts. But I do know that I encountered at least 3 different care providers who used that phrase before I did in our conversations. And I think, Dr. Stepanenko, I think you were one of them that used that phrase before I did. I mean, it was in my mind, but I think we were both, some synchrony going on here. So the phrase itself, like the concept, is intended to be just very pragmatic, and it is imperfect. And there are certainly people who are not technically military special operators who have the syndrome. So for me, the main exposure, and we've just kind of opened the door to the discussion of exposures, but for me, the main exposure is the blast wave exposures. And that's everything from breaching, demolitions, firing rockets, but even pulling the trigger on a handgun or a rifle, involves a micro exposure. And everything else that goes with that. So the heavy metal exposures and some of the other things. But we now have a much better understanding of traumatic brain injury than we did even a decade ago. So we know that impact forces and blast exposures cause different types of damage to the brain.
Dr. Frueh, thanks. Hold on, Bryan. And so what I want, because I'm going to work on to some more sort of compound questions here we've got so we can make time. But there's, speaking of time, so there's one question here, and Dr. Frueh, if you can answer it. And so basically is there a time service requirement for operator syndrome? And I think that's key, right? You may not have the perfect answer. I know your honesty, because for the longest time I figured, well, I didn't have it, and I did 20 years of nonstop in the organization that was in until I got spit out into the VA system. And then looking back at all the criteria, as you guys mentioned in the patterns, I'm like, oh, I definitely had it. But as a guy who retired as a leader from the Army, I said, well, I wish I could go back and at some point identify, I'm assuming that once someone goes and starts work, they're about going to start gathering essentially what we're calling this operator. So just being in SOF, being an operator, and what we're throwing these people at and their families, you at some point are going to get it. So I think it's good to understand, just like we understand Stockholm syndrome, right? We work backwards from those magical hours. But when we work backwards from operator syndrome, so if you could, Dr. Frueh, just in a few minutes, is there not a service requirement? Time, excuse me.
I would say no. I would say there's no time. Now, I would say that the operators that I've talked to who had 3 or 4 years in, maybe were not as severely injured as people who had 10 years in, who are not as severely injured as people with 20 or more years in. But if you take somebody who's been through one of the selection courses for any of the branches, and then the first training evolution or two, what are you looking at? You're looking at somebody who has put their body through an intensive crucible that includes an enormous wear and tear and potential damage on the body. I mean, Hell Week, let's just take BUD/S. Hell Week in BUD/S is a week of really no sleep. And we know that going without sleep is not good for you. Probably a more defining aspect of what might be causative are the early training experiences with explosives. Anything involving explosives, blasts, that adds up pretty quickly, I think. And I think there's good data that suggests that when you consider the TBI prevalence in service members, when you start looking at operators, most of them have TBI level exposures very early on in their careers. And then the longer their careers, obviously, the more those exposures accumulate, plus other exposures, and plus just the internal effects of all that, of chronic stress with a high op tempo and sleep deprivation.
No, thank you. I think that was perfect. I think that's key to capture. And hopefully there are some leaders, some current operators, or some former guys or family members, right? I think the family members know us way better than we know each other. And I think some of the key things that you said are important, because it isn't only that combat, it is everything in between. I mean, you said sort of the blast, but then also the next week the guy went on a jump, he had a bad hard landing, it bumped his noggin, and he's like, oh, that's just normal. I just I hit my head, or I was wearing the camera. And you're like, well, that was just a whiplash from the camera, that's no big deal. But to your point, these things add up, and hopefully later on we can kind of discuss how maybe we should track the bruises and the concussions and what these guys are experiencing. So on that note, I'm going to go ahead and it's great to hear from your experiences and to learn about operator syndrome, because I think it's important. We're putting a name to life we go through as the operators, current and former, and their spouses. We've had some questions that rolled in from our participants, so I'm going to go ahead, and I think some of these have been briefly answered. So if you've kind of talked to them a little bit, we'll make it short so we can continue to get through it. So the first one is there any link between exposure to explosions and firing weapons to long-term symptoms such as headaches, body aches, muscular pain, and chronic conditions? I would just say check. And the second part of that is, do these symptoms become worse over time, causing individuals to have sleep disturbance, mood swings, depression, and irritability? I think we just hit some key points there. So I throw it back to the panels of doctors.
Yes, and yes.
I can mention a couple of mechanisms and just, I jokingly say geek out, but allow me to geek out with you for a quick second here. So blast exposure, TBI exposure, whether or not there's loss of consciousness, you've got neuroinflammation pathways that get jump started. So now you've got brain cells that are essentially on fire or injured. And there's an inflammatory process that goes along with that immediately, but then a downstream later cellular dysfunction, metabolic dysfunction process that continues for the long term. Now, not only do you have that neuroinflammation process, but you have, and we've got bodies of evidence to support the next step, that TBI leads to microbial disruption and changes in gut function. And we're talking about three huge drivers of dysfunction here. So anytime you have a TBI, you're going to have a leaky blood-brain barrier for a brief transient period and a leaky gut barrier for a brief transient period. Now, that's body-wide sources of inflammation and can key off your immune system to have some dysfunctional patterns of immune system function. But then after that, the blood-brain barrier comes back to normal, if it does. After that, gut barrier comes back to normal, if it does, then it can change the way your brain is talking to your gut and telling it to function. So some people will have chronic constipation issues or even irritable bowel syndrome pictures after a history of blast exposure or getting blown up, as they'll say. My gut's never been the same since. Even some of the medication treatments that are tied to some of the TBI related symptoms or the sleep dysfunction picture afterwards can further contribute to gut dysfunction, inflammatory system kind of potentiating them. I'll try and not use big words throughout this, but please tell me if I do, and I'll explain it. Thank you.
Yeah. Well, just to zone in on one area that Bryan is talking about, it is what is the cool down period between one exposure, one TBI, and the next, right? Because if there is not an adequate cool down between, then you begin to have kind of a compounding problem. And we have protocols in the NFL for managing a head injury, right? It took a long time to get there, but they finally got there. And so people can't go back into the game until that is cleared, until they have been cleared, at least neurologically. That's another aspect of what we need to be able to define over time, is what is an adequate cool down period, which is going to be a big problem for operators because they don't want to be pulled out of the action, right? They're just like the NFL players. They want to be in the action. But if we're talking about, I think, Erick, you described the $1 million piece of equipment that they're willing to pull off to service. We have to kind of change the narrative around what's okay to be out of service for a little bit. And, can you, in fact, give your body time to recover?
No, thank you both for that. Bryan, I think you just said something that, you probably saw the intensity in my eyes because you said the gut. I never thought I had a gut problem, and this is probably going to be a little bit more than people want to hear, but there's a point to this. Is till I was retiring and I went through the NICO program, the National Intrepid Center of Excellence for Traumatic Brain Injuries, one of the most disappointing diagnoses that came out was that I had celiac disease. I'm Latino. That means I couldn't eat bread, and I couldn't drink beer, and I was in shock, and I was in absolute shock. And I'm like, what do you mean? What is this gluten thing? And bottom line, at NICO specifically for traumatic brain injuries, they equated that to my inability to process the nutrients that I needed for my brain. I mean, that was simple. This is like Marine, 101. I'm a Marine, so I can say that. And so the doctors there were like, till you fix your gut, I can't help you get the nutrients into your body. And so this was, to me, I picked up the phone, called a couple of friends, and I'm like, hey, man, we talk about this issues with our gut, and it's just part of the bad food we ate in Afghanistan, the crappy stuff that we ate in Syria, blah, blah, blah. It was somehow, they were trying to equate the traumatic brain injuries, I had several of them, back to when there was an issue with my gut, right? And so Did that matter that no longer I can eat bread? That was only one piece of it. The key was I wasn't getting the nutrients. So till I took care of the celiac, which by the way completely affected my joints, right? So a lot of operators are like, "Oh, my hands are going bad. I have arthritis. I'm getting old." No, it was actually the celiac was affecting my joints, our joints, and also the sleep, which are keywords you guys just said, right? The brain, the sleep, which then was the mood because I'm not getting enough sleep. So thank you both for mentioning those because I think those were huge key points that hopefully folks are hearing and they're going, "Hey, this is just not something that just bother us as kind of GI problems. These are things that could be equated to the larger kind of, hey, put this on a whiteboard and put down your syndrome and put down what you may have going on with you." So those are some key points. Let me look at the updated questions because you guys have been answering some great questions. So we've got one that came in on the chat specifically for Bryan. It says, what constitutes dysfunction? What is fully functional and effective on mission at work is not functional at home or in society. Over decades of war, it is tough to switch back and forth, so you stay on. Also, a matter of time horizon, short-term versus long-term, and life. Deployments are a great example. No sleep, aggression, etc. That's a great question. Bryan?
Phenomenal. All right. I appreciate the question because my wife asked me the same thing as I was preparing for one of our 4-hour workshops where we talk about military operational exposures and root cause dysfunction. I made this fantastic handout that really laid out all these check boxes and ways of thinking about the problem. But my wife said, "Hey, that's fine and dandy, but what does right look like?" Like me as a wife, if I've got a husband, that's having these exposures, that's too much. What is simple? Like, what does right look like, and how can I support right from home? And I came up with a total separate handout, me and like frameworks and thought processes. So I made a total separate handout of, hey, here's the 30 things we can do for what right looks like, and really it focused on optimal function in a couple of specific areas. One was sleep. Like, what are good sleep patterns? How can I support the best sleep possible? How can I minimize disruption and maximize the recovery that happens during sleep, but also the hormonal production and the metabolic function that happens during sleep? So sleep, critical. Getting right sleep, not only based off of do I go to bed at a consistent time and wake at a consistent time, but is it truly restful? And how can I track that at home on my own to raise my hand early when it's not quite right? So sleep, huge. Nutrient status, your ability to choose healthy foods that contain the right type of nutrients that maximize your resilience, your immune system function, your gut function. So what does the right type of nutrients look like? Am I getting the right amount of specific types of nutrients? Things that are magnesium containing, zinc containing, selenium containing, things that maximize your body's ability to manage and make hormones. So nutrient status, and you can get advanced testing for nutrient status to see if you're breaking down macronutrients, utilizing them appropriately, whether or not you have the right vitamins and minerals based off of what you're doing and what your performance patterns and recovering patterns are. So nutrients is another one. And then gut function. I mean, you touched on it and I'm talking about it, but it is critical to your ability to digest food, assimilate nutrients, and a majority of your neurotransmitters like serotonin, dopamine, all these neurotransmitters rely on your gut's ability to do its job right. So it means starting with the gut, huge. So hopefully that's a resource we can share a little bit later, but there's ways of optimizing gut function, sleep function, nutrient status that build up your force field and make you more resilient to the day-to-day unavoidable exposures, and to maximize that recovery process, optimizing the healing potential, especially for brain, for nerves, for gut, that type of stuff. One comment I do want to make, another downstream effect of TBI, and this is a personal story, a total wake-up moment for me. After 4 years of med school and 2.5 years of residency training, not once had I heard a term that I found out when I was talking to Jeff Dardia, and he was saying, people are talking about this. This is known in the military health system, but not once had I heard it at any point, and that's neuroendocrine dysfunction. So the concept that you can have a TBI injury, that neuroinflammation can persist to where some of the tissues don't quite bounce back. And it's not just certain portions of the brain, like your front portion of the brain, that regulates your mood and emotions, to where if that injury persists, you can get regulation of mood, regulation of behavior issues, irritability and outbursts and anger to where it's difficult to control. But specifically the pituitary gland. Pituitary gland can take a hit and you can get either compromised blood flow to portions or the whole pituitary gland, or you can just get injured pituitary gland that doesn't quite do the job the same ever since. And that can lead to issues in your ability to produce and manage testosterone, thyroid hormones, your adrenal glands that manage your cortisol levels. And that can have a huge downstream impact to where you may still produce normal range numbers, but normal range is not optimal for a person with this performance demand and rates of exposures. So that's a big thing I wanted to communicate.
Now, Bryan, go ahead, Chris.
I was just going to add estrogen to the list of hormones that Bryan listed. I've talked with a lot of guys that report elevated estrogen levels there. And a few years ago, there was a surgeon at one of the VAs, I think it was in California, who reached out to me. She said she basically was in a clinic. The surgery she was doing was breast removal, breast reductions on men who had elevated estrogen and reduced testosterone. And all the men that she was working with were essentially operators. And so here was this whole thing that she didn't understand herself, and they didn't understand it. And so once she started connecting the dots, it was a large exclamation point for her. So the hormones our hormonal dysregulation is absolutely a huge part of the problem here.
And Frueh, you mentioned before how sleep dysfunction easily follows a brain injury or some of those crucible type exposures, to where another downstream portion of brain dysfunction that can follow is the ability to regulate breathing during sleep. And sleep apnea, it's not always obstructive sleep apnea. And in fact, it may not be primarily obstructive sleep apnea, but sleep apnea being a part of this total operator syndrome or high allostatic overload picture, critical to identify, foundational to health, metabolic health, hormonal health, the ability to produce and manage it. So I think we're missing a lot of the sleep dysfunction. And I love that people are incorporating wearables and tracking their sleep quantity, quality, function, and some of these high-tech ones that incorporate HRV, stress throughout the day and during sleep. Some of them even incorporate oxygen levels throughout the night. I know Garmin device offers oxygen monitoring throughout the night as well. And I think those are opportunities to identify some of these sleep dysfunction patterns early. Raise your hand early while you're still in the game and say, I'm not sleeping quite right. Here's my information. Help me figure out what I got to do, because this can't persist.
I think those are two key points, and I'm going to just make a quick comment, and then I'm going to jump into another key question or aspect of it. But I'm going to wrap up just sort of from my perspective as a knucklehead at the end. And so to your point, Bryan, like I don't sell these, the Oura Ring, right? So this Oura Ring, I used to tell myself I got enough sleep, right? That was 3 and 4 hours of sleep on exercises or deployments, or I would come home, as I would say, I would come home on TDY, and then I would go back and deploy, because I came to TDY to see my family. And then when I was here for those short weeks or days, I wouldn't sleep. And my wife would candidly say, "You're a freaking zombie. Go to the guest bedroom." Right? That was a key indicator. And it wasn't just a snoring. It was like you're twitching, you're turning, you're irritable, you're not getting sleep, and you're just a mess. So sleep was the number one thing that I would say is probably something that we should consider, is why are we and again, this is a very broad question, why are we waiting till service members are getting ready to retire to do a sleep study, to then issue them a CPAP machine and then get them out? Why don't we start giving these guys, I wish I would have gotten a sleep pack machine once diagnosed, right, from the beginning. And why I mentioned the Oura Ring, it's because, I've learned to tell myself I can keep on going as part of our DNA. But there's little rings actually telling me, "Hey, knucklehead, no, you didn't get enough sleep," or "You did get enough sleep because you did do your golden hour. You did do, you didn't sleep, or you didn't drink late at night. You didn't eat at 9 o'clock at night." So it helps me from a data proven perspective to realize when I'm not sleeping. And I'll tell you the number one thing and I've spoken to a lot of former guys. Sleep right now, it's the most important thing to me because it's my basis. And I'll tell you the one thing, we know how to heal body parts. We've had the best taking care of our body. What's really hard to take care of is our minds, our brains, our cognitive. And a lot of operators, once we start losing that cognitive, we lose memory, we can't think as well, we can't process, we can't react. That's when we kind of feel like that thoroughbred horse that just needs to be put out. And that's what we got to work backwards. I can simplify it there. And so with that, unless there's any other comments, I'm going to go to a big question. Where's the controversy? This is a topic that everyone talks about, but it is in many ways an elephant in the room. Why is the topic so tricky to get help for or even talk about? What evidence is out there? So I pose this question to our panels.
Well, to borrow from another area of medicine, and that is physician burnout. What we're describing, maybe with the exception of TBI, is what we see in physician burnout, nurse burnout, in the healthcare sector. And the controversy is the same there. What is the controversy? Well, if you poll doctors and nurses and you find out that 65 to 70% are experiencing high levels of burnout, then the healthcare system, the employers need to do something about it. What is an adequate response to that burnout? And then at that point, when money starts to hit the fan, that's when you get a great deal of controversy. Well, is this really burnout, or is this dissatisfaction? Are people looking, what are the different motivations and reasons for this kind of a thing? And I think this is one of the reasons why we place so much emphasis on the physical, the biological components, not just the stress, although the stress is exceedingly important. And so that is, at least in my view, part of the controversy beyond what we yet do not know about the syndrome.
Anybody
Erick,
else?
Could you maybe explain what say a little bit more about the controversy? Because I'm not sure there is a controversy.
Okay, that's a really good question.
Like what makes us
because
say, what makes us think there's a controversy? Maybe that's what I should have asked.
Is it in the name? Operator syndrome, that we're saying that there's something wrong with us?
Okay.
Is that what we're looking at? And Kaylee and Lindsay, please jump in if that's where we're looking at that.
Okay, so it could be about the name, and maybe we just don't have the right name, or maybe we are talking about something, maybe the controversy is we shouldn't even be talking about these health issues or functional issues.
Yeah.
I definitely think.
Yeah,
Go ahead,
sorry.
Kaylee.
Yeah, sorry. We get this a lot on our end at the Military Special Operations Family Collaborative, because we uniquely talk to and relate with many stakeholders. So we get all the questions from providers and military leaders and family members, and I would say there's a bunch of issues tied together. For some, there's concern. It would maybe hurt things such as recruitment, or it would indicate that if you serve in special operations, especially under certain circumstances or a certain duration of time, that you're bound to get operator syndrome, and that can scare people away, and that's a valid concern. And there's others like that, and I would say one is a concern that the name and the conversation is ahead of the research. So it's in using appropriate caution and engaging stakeholders, which in my view is challenging because many people are afraid to start the conversation, which is one reason we're hosting this event tonight. And I'll pause and let others speak. Eric, I see Jeff has his hand up for a moment as well.
Can you guys hear me, Kaylee?
Yeah. Mm-hmm.
Hey, so I was going to say, from a guy, I teach about operator syndrome full time across the enterprise as a DoD position within SOCOM. And the big thing is what we talk about. These are expected responses. It's like throwing someone into a fire. You're going to get burned. There's going to be things that come along with this type of work, and it's not unique to the military. But what we have to look at is like three statuses. You're either thriving in your environment, you're getting by in your environment, or you're surviving and scraping, right? And if you know that as an individual, am I performing to my full potential, or am I just getting by? What we're doing is putting this on a scale of red, amber, and green. And we teach about the health effects of the operational environment. And then when people are getting to a point where they're not adapting well and thriving and just getting by, that we can interdict as providers and programs and help those guys get to the next level. And we've broken it down to 2-level maintenance: operator level done in the field by the individual, and then level 20 and above at the depot, just like we sustain our equipment in the military. That's all I'm going to say about that, guys. But it's how you approach the commands. But again, this is an expected response. You're going to get burned in this environment. It's normal.
Yeah. And to piggyback on some of what you said, Jeff, and Tracy in the chat, this is a fantastic point. One of the controversies, especially on the civilian side, it is the lack of research that there's not an ICD-10 like diagnosis code that can be attached, which is complicating, especially because like even if you just have one chronic health condition, getting care for that one condition can be really hard in the civilian system because of how the medical care in the country is currently. So when you throw in multiple chronic illnesses, it can be really frustrating and hard to care for patients as a provider, but to seek care as a patient. And so I think that is some of the anxiety behind some of what we receive on this end, who want the research put together better so they have the tools to give patients and families and operators who reach out.
Kaylee, I got to piggyback a comment off of what you're mentioning now and what Jeff just mentioned. So I think a higher priority right now is getting to a shared understanding as opposed to conducting the actual research. And I feel like I got to lay out a concept real quick that I think will be helpful to the conversation, especially around shared understanding and total allostatic load, contributing factors. Because the research is there for each of these components. So real brief, an acronym that Jeff and I use to teach about military operational exposures is STAINED, STAINED. And it's sleep, stress, SNPs, toxins, trauma, tablets, and trauma can be psychological, it can be physical, it can be blast overpressure, it can be TBI. So that's a big, broad term. Tablets can be related to medical treatments or, unintended consequences of pharmaceuticals. And then allergies and autoimmune, so the loss of self-tolerance. And that can go hand in hand with intestinal permeability, which we know happens with blast exposures and TBIs. And with allergies, it's not just allergies outright, swelling and red immediately after exposure. It could be sensitivities and intolerances as well. So subclinical symptoms that persist. Infections and ingestions, so substance use or self-medicating behaviors, that's part of it. Nutritional excesses and nutritional deficiencies. Now, if you're deficient in certain key nutrients, then lead looks a lot like calcium. And your body becomes a sponge if you're deficient or relatively insufficient in certain key nutrients. So making sure you got the levels all optimized for key nutrients, critical. So nutritional deficiencies and nutritional excesses. And then recently we added an E to the acronym, but that's EMF and radiation exposure because it didn't quite fit anywhere else. And that's definitely an exposure in total for a lot of these operators. And then D was digestion and dysbiosis. So all of these are factors and all of them have research behind them of total exposure, the dysfunctional patterns that can result from it and the downstream effects, health effects on the body, the person, the individual. And really, it's the totality of exposure. Like Jeff said, you know, you throw someone into a fire, you know, you're going to get burned. The question is how much and how bad. So I think the research moving forward will need to focus on some way of evaluating that individual snapshot at baseline and at interval, and their patterns of function, their functional status in certain domains. And that should be microbial, that should be metabolic, that should be hormonal, that should be brain function, that should be gut function. I probably mentioned that already, but I think there's ways of setting up a framework of how to assess somebody's total function status in all these domains right now at interval. And as you put them into these exposures, these training environments, these garrison environments even, how does their functional status change over time? And being able to put it in a red, amber, green status, like Jeff said. And then Jeff, pairing that with personal protective nutrition, personal protective lifestyle. So key interventional strategies, ways of utilizing the services and resources around you that you have access to. You know, those performance teams and those healthcare teams, how can they help you with some of these level 1, level 2 maintenance strategies like you're talking about, Jeff? Thanks.
I think one of the things that we haven't really put into words yet, although I think it was in the comment section, just scrolling back, Tracy's comment. There seems to be a fear among leadership. I'll just say leadership, whether it's VA, DOD, hospitals, clinics, insurance companies. There seems to be a fear of, I mean, let me back up. We clearly have a fragmented healthcare system. You go to one person to have your eyes checked, you go to another person to have your teeth looked at, you go to another person who's the specialist in X, Y, or Z. And there's not a lot of integration of the different care providers working together. And I think that is why that's part of what I think the point of operator syndrome is, to sort of make it clear that these different problems are all interrelated. They affect each other, they cause each other, they reinforce each other, they maintain each other. But it also represents a chance, if you can make changes in one area, that can have benefits in other areas. And I think all of us here have been talking for quite some time now about the importance of having a more cohesive, more comprehensive approach to medical care. And in Tracy's point about, well, providers are all overwhelmed and they're overburdened and they don't have time. And that becomes like, is that our reason for not taking good care of people? Because our providers are, the answer is we need to change the way our systems work, and maybe we need more providers. I'm not quite sure, I'm not even gonna say I have the solutions, but I don't think it's okay to say, well, we're gonna ignore complex medical problems because we don't know what to do about them. And I think that's what's happening.
Chris, I definitely agree with regards to fragmented care and being overburdened. I think there's a different skill set and mentality that comes with the type of medical care experience that we need to be trying to achieve. So healing faster and being unbreakable is on a very different part of the spectrum from saving lives and keeping guys in the fight. And we are amazing at deployed medicine. We are amazing and continue to make advances with the healing faster, being unbreakable, and from point of injury and saving lives. But when it comes to that healing faster and being unbreakable side of the spectrum, that's a very different team member. It's a very different team lead. Like, you need to have very different skill set. One group that I think is on the right path, the Air Force is actually leading the way with a working group at some of the highest levels of the military health system called Lifestyle and Performance Medicine. And Lifestyle and Performance Medicine Working Group is focused around leveraging lifestyle medicine and integrative approaches to address root cause dysfunction. And I think functional medicine is synergistic to the Lifestyle and Performance Medicine Group working group's efforts. I think that skill set and that area and those type of clinical champions are going to be helpful for building out that healing faster and being unbreakable focus. I think that we need a human performance and wellness physician role that we do not have. That's a job that doesn't exist right now in the military health system, but someone whose job it is to optimize that individual, to evaluate those areas of function and I mean, there's trainings and skill sets that go hand in hand with that I don't think are quite paved and established in the military health system right now.
Agreed. And Jeff just said it very nicely. He said, if we can, we do teach our operators how to operate, maintain, and repair their weapons systems and their equipments. Why don't we do the same thing for how to maintain, operate, and repair themselves, the human? We always say humans are more important than hardware, but boy, we sure don't put our money where our mouths, where our statements are.
And Dr. Free, I'll jump in that. I mean, these have been some amazing points, you know, and I want to say probably, you know, we understand it can go down to culture, right? I wish I would have been here in this conversation. I was back in the team room and able to just at least at a small team room with a bunch of guys go, hey man, you know, you need to take care of yourself. I know you're breaking down. I know you can't sleep. I know you're stressed. I know you're having issues, right? And especially as leaders, when we're caring after our folks and we know these people, we know their families, especially in SOF. We create bonds and we know these family members for a long time, and we can start telling when they're having issues. So hopefully, at least operator syndrome starts a way that we look at each other and understanding, you know, it, with some level of hope. And as Jeff and some of the other guys have said, this is inevitable. This is going to happen. These studies are alluding that this is what's going to happen if you're in SOF and you're operating. And in particular, these last 20 years of GWAT, it's just been nonstop. And so the other one, you know, when we work backwards, and it's not that this is what operator syndrome leads to, but as a guy that recently left the team room and was saddened, I've had 2 operators commit suicide. I can't say because it's private why they did it, but they were guys on the road, guys that came back from the trip. And as I was retiring, we had one guy take his life, and we just say, you know, can assume that he was definitely dealing with PTS and that world around him, because he had been in the organization for almost a decade and he took his life. And then a month later, another one of our teammates took his life. So I can't point to our operator system, but I can tell you that we can say they were probably run down, and the effect of one catered to the other. And so a guy that's more concerned about the folks that are listening now, to the family members and to those that are in active service, that's at the end, that's the worst thing that can happen, right? And I'll take a minute to also equate to, we've talked, you know, the SOF principles that humans are important. But I think, and this is just Erick, who's been out for a while, you know, we do look at hardware in a different perspective. I can tell you, have been involved with aircrafts and boats and very expensive hardware. That commander would know a year out if that plane or that device had to get phased, if they had to change the ball bearings, when did we need new parts, how much was it going to cost, all the way down to the ones and zero. But should we be taking an approach where we say, hey, we're going to take care of our operators and their families, if you would, in the same way, where we're tracking their deployments, what happens to them in their lives, all of these things. So sort of like Jeff mentioned, sort of OP, you know, we're looking at it from ahead of time, and we're like, hey, buddy, you may need to take a knee, or we need to get you to some level of help to get you back into the fight. And I think that's the key. You're not broken. You're not getting sidelined. We're going to make you better and stronger, and in particular with your family. So unless there's any comments, I'm going to go ahead and move us on to
just one quick one, Erick. You know, your last point is just, it's gold, right? You reframe, you rephrase, and you change the conversation from illness and failure to retool, reshape, be better. This was Jeff's point in the text exchange, and it's perfect, because then you get buy-in. You get real buy-in from these guys, right?
Well, you're talking about performance optimization.
Absolutely.
And who doesn't want that?
Exactly. I give talks all the time to physicians and surgeons, et cetera, to do, you know, wellness-based practices, meditation, et cetera. And, you know, I get stares and I get looking down at watches, et cetera, until I say, oh, yeah, and if you do these things 3 times a day for 10 minutes, you'll be a better surgeon. And then, oh, they get interested, right? Because, oh, you mean this is going to have an effect on my fine motor control? if I'm calmer when I walk into the OR? Yes, the answer is very simply yes. Sports medicine, I think the reason that that has taken off is because athletes understand, oh, if I do these basic, simple things, it improves my performance. And we need to get that front loaded everywhere that we can.
One personal
Yeah,
experience I just briefly, want to share is in the clinical setting when I was over at Fort Bragg for 3 years, dealing with some SOF veterans and conventional active duty guys, trying to figure out what those guys care about and framing the conversation of how these things that you're doing, thinking, or eating matter, mattered most to them when I was talking about brains, guts, and nuts. And quite literally, if it was related to brain function, cognitive function, their ability to focus, pay attention, remember, and perform cognitively, okay, gut function disrupted, they know it. And if it's not working right, it's probably not been working right for a while, and they care. And if it's related to sexual function, their ability to perform, or their hormone levels, they'll bring that up to me, and that'll be the initiation of a long conversation, because I get to shift it into helping them understand how what they do, think, and eat matters. And that's the beauty about this functional medicine training and education, is that we can have that conversation. I can spin any topic and make it relevant to what you're doing, thinking, or eating. So there is some locus of control.
Thanks, Bryan. Thanks, Chris. I'm sorry, Chris, did you have another comment? I see you're unmuted. You're good? Okay. No, those are great points. And just to, before I get into the next one, definitely the cognitive and looking backwards, and if it means anything, and this is just talking to other friends were, retired guys, and we're looking around and going, hey man, post, your 10, 15, 20 years at these commands, at these SOF commands, what was the number one things that really bother you into your next life, right? So if we quickly talk about the veteran life and that family, which will soon will be the guys that are on active duty having to roll over, and a lot of them were cognitive. And I know we've mentioned this several times, to lose cognitively and to just feel that decline. And then how we became as individuals with our family, right? There's no more deployments. There's no more TDY. I can't even get back in the building because my badge is turned off. So now I've got to come back to the reality of 20 years being away from my family. And so the cognitive piece and somewhat the behavior, I've gone back and we've looked at how did we perform? Did we see a decline in our NSOERs, our evaluations at enlisted or officers, where we started to see this going down? Did we see some of our test scores, at least in languages and other things going down? And I bring this up because there was some questions about data, and we can probably continue this conversation another day of what's needed, because it seems that there's a lot of folks here that want to help. So I just want to kind of make those points as we continue to get the comments in chat. Lindsay, I see your virtual hand up.
Yeah, thank you for letting me jump in here. I just wanted to ask from sort of spouse perspective, and maybe any family members in the audience might also appreciate this, but practically speaking, pending a wholesale revolution in the military healthcare system and culture in general about healthcare, how do we go about talking to the service member if I'm a spouse and I notice some things that are going on? And then how do I encourage my service member to talk to his primary care manager, and what would he say? If we're talking to doctors who are, no offense to any doctors, I don't think any of those doctors are here, but the kind who are just, treating specific injuries and not necessarily looking at it from the whole person, holistic perspective. How do you engage with your doctor if you're an operator and you're noticing some of these issues?
I can start to try and attack the question, and I truly, truly appreciate the question. Invaluable one here. So, from my own perspective, the best type of patient is one that comes to me with a clear understanding, or even a gist of, hey doc, this has happened to me. This is something that I'm doing. What's the impact of it? Or what could go wrong? How would I know? And what can I start doing now to try and reduce the impact of it? Or when would I need professional help or other help? So having conversations early on, if there's known exposures or known incidents, persistent dysfunction beyond what was originally being told to that individual is normal, that needs to be brought up and discussed early. And sometimes bring that conversation, starting that conversation needs to start with somebody else. And real quick, just from my perspective, I think family members and providers, PCMs, primary care providers, can help by doing four things in total, but really the first three are advocate, investigate, and educate on behalf of the patient. Hey, doc, help me learn, help me understand. What do I have access to? How does this work? What's happening to me? And what can I do? Questions like that. We can advocate and put them in touch with resources or even investigative research studies that are ongoing. So we can advocate for them and put them in touch with people that could help them further. We can investigate things and look into something more or see if there's been any patterns of other people with similar issues. And we can educate. We can look into something in depth, take that time in the background and bring it back to you and learn together. So if there's a doc that has no training about what this exposure in particular can do, then the right type of answer in a conversation is, let me look into that. I'm going to look into that. I'm going to learn more. I'm going to get right back with you. And if that doc's not telling you that, then maybe they don't need to be your primary care doc. Maybe you just need to find another opportunity to connect with somebody that will educate themselves, educate you about what it means, how it impacts you, and how to do something about it. So advocate, investigate, educate. I think family members can do that. I think primary care docs can do that. But then the support and accountability component is it's critical, because they're part of your team and they should be part of your team. And you should have trust and confidence in your team. And if you don't, then there are other opportunities to establish a trusting and cooperative relationship with somebody who has a shared understanding that is part of either the medical team or in your social circle and family network. So really that trust and shared understanding are critical. And sometimes it's the person next to you. Sometimes it's finding someone in your professional setting that's been through a similar struggle, had a similar issue, presented with similar symptoms, that can tell you about their experience and what they know and what they don't know. Sometimes they can just put great questions in front of you. And now you've got something better to run with. Over.
So Lauren just posted okay.
Go ahead, Chris.
Lauren just posted a very fine recommendation, which is operators talking to operators, right? And one of the reasons that might work really well is because they're part of the team. They're part of the known team. They're part of the ongoing team. And their ears might be open more. I'm not being silly about that. I mean, literally their inner ear muscles open up more when they feel that they trust the person that's sitting across from them. So, how do family members do this? Well, they do this by coming towards the loved one.
Like, wow, maybe we're hanging up the conversation.
We got a hot mic.
Okay. Yeah. So they come towards them first, kind of like you would with any kind of worried or scared animal or child or person. You come at them kind of very gently, softly, obliquely, and try to talk to them. It's really difficult to say this would work with every person and every family, because some people respond really well to, hey, get off the couch now, we're going to have a conversation. So what I'm suggesting is not going to work for everyone. And just think about this the other day. Lindsay, your question's great, and I think this is something where a group of family members of SOF would actually do really well to get together and have these kind of discussions. There is a really fantastic model for this. It's called multifamily systems groups. And I'll send a link over a little bit later about this, where people who are facing very similar kind of difficulties with loved ones who do not think that they have a problem, do not think that they have issues, and rather than experts tell them how to do it, they get together and say, you know what worked really well in this situation? And they share and they crosstalk and they support each other. And these groups can go on for years, and they're very helpful to the loved ones around them. It brings down their allostatic load because now they've got a trusted group that they can work with. And if people are interested in putting something like that together, I'd be happy to help get that rolling.
I love that idea. I think another opportunity to explore the peers sharing experiences or the birds of a feather identifying with each other and growing from each other's experiences is something that the VA is actually doing really well right now. And just bear with me here, but the VA, the whole health system has peer health coaches. And peer health coaches are individuals that are motivated and have some skill sets to where they can communicate well, and they champion certain aspects of health and wellness, but they've benefited from the system. They've had the health struggles, they've gotten themselves better, they've engaged the system in a successful way, and they want to give back. And imagine if we had something like that. Imagine if we had some peer health coaches that were SOF operators who have had these health challenges, navigated systems successfully, and want to give back. And if they had an outlet, an opportunity to provide support and accountability and help people through these experiences, imagine if someone engaged Care Coalition and they were immediately paired with a peer health coach. And now you had someone just like me that struggled just like me and was able to navigate the systems, the foundations, the civilian sector, nonprofit sector, and military health system sector services and resources. I mean, that would be game changing. But I love the concept, like you're talking about, groups.
Thank you, Brian. Thank you, Lindsay, for posing that question. There's been some just amazing chat. I can't read that fast. Luckily, Lindsay's writing all these down. I think two key things that came out of it, and it's kind of been some of the genesis for a lot of this is, and I don't like to use the words, but, operators talking to operators. So what does that mean? It is at the end, at some point, we become, vulnerable, and it is a strength, right? Many of us have been leaders. Many of us have been, folks that have helped other operators become operators and specialize. But I'll tell you, in all those years, the most powerful thing that I've seen, just to throw some names, the Tom Satterlees and Tom Spooner, the Clint Trials, the Marines, the Air Force, these leaders, these individuals who've come in some aspect, shared their story, shared their struggle, right? And some of them, it's black and white here. They were at the end of their bed with a 45 in their hand, right? And they worked and they walked backwards from it, and they talked about it. I will tell you that from those of my other friends and people on the internet now, communicating with other folks that are interested, this even extends to law enforcement. It resonates. People are saying, thank you for what you said and how you laid it out. And I listened. And then I went and I asked for help, but it was till they heard somebody that they can, it's kind of at the same level, if you would. And I think that makes a difference. So thank you for asking the questions. I think there was one about female operators. That's probably something that we do need to cover at some point. Now, just for the interest of time, because I know we're going to get to kind of the last part of here, where we're going to have a little bit more dialogue. I'm going to get into seeking intervention. And there's some, I'm going to choose one or two questions unless they're highlighted for me. So we've spent some time unpacking the topic and why it is challenging to understand and even talk about it. It is going to take time for evidence and care to catch up with the need. For those who need help, how do they find care? Which I think we've kind of talked some aspects of it on the medical side, and just other people just sharing their stories. And what is the role of a primary care doctor, counselor, and most of all, our own families? And so I want to have one that, and just mentioning sort of Tom Spooner, and so for this one would be, why does substance abuse mess up the healing the illness in operator syndrome? So I pose that back to the panel.
From my perspective, oh yeah, Free, go ahead, lead the way.
Go ahead, Chris.
I was just going to say, before we even get to that question, I think could we back up just a little bit to talk about, where do you begin? You're an operator or a spouse and you're seeing some of this stuff. Where do you even begin? And I think you kind of have two very general choices. One is to try to find a way into one of the TBI, comprehensive TBI programs that are usually 2 to 4 weeks in length. NICO, the Intrepid Spirit Centers, Home Base, there's a few others, but there aren't enough slots. There aren't enough slots in those programs. So the other way is to essentially find some care provider who either knows something or is willing to be humble and curious and listen, and who can then have the ability to help you quarterback your care. So that's usually going to be a primary care doc, somebody like Bryan, I think. We don't like, do we know all the, yeah, sorry. Right, exactly. Dr. Bryan, the unicorn. You are a unicorn, man. You really are. We can joke about it, but you are.
We've been force multiplying.
I think there's some very simple things anybody can do, and it doesn't have to be at a fancy, complicated, world-class program. Anybody can ask their primary care doc for a sleep study. That's one thing, easy to do. Another is to ask for a blood panel that includes hormones. Relatively easy to do, not all that expensive. I encourage people, or just for lack of a better strategy, I encourage people, take this paper, take the operator syndrome paper and highlight the parts of it that makes that resonate for you, and take that in and talk to your provider. Just show it to them, let them read it, educate them, and then ask for their help. We do have good standard treatments that will go a long ways for a lot of these conditions. I'm personally a fan. I don't mean personally as in I've had it, but I've seen a very effective use of stellate ganglion block treatment as an early treatment. Low risk, seems to be very, very profound and immediate benefit to people. And then you can go down the list. Psychiatry and psychology have a role. Sleep medicine has a role. And then you get into some of the very specific treatments like ketamine therapy, speech pathology, transcranial magnetic stimulation, hyperbaric oxygen therapy, even psychedelic medicine. So there's a lot of treatments out there. Part of the challenge is finding the right way to sequence those treatments and to figure out which ones are going to be the most bang for the buck for you as an individual. And not everybody's going to have the same experience or the same benefits from one treatment to the next. Bryan, I pass the baton over to you. So you were about to say something.
I love what you said, and how sometimes what's needed from the primary care provider is just a connection to other resources or programs. And sometimes if they're willing to learn, to grow, and to educate themselves and you, the person bringing up the concern to them, then they're going to be willing to learn about the program you're trying to get connected to. They're going to be willing to understand more about the handout that you brought or the paper that you brought. So really just having a productive conversation like that and creating some of these communication tools, like operator syndrome paper, or like some of the handouts that I know SOF has been creating. SOF has been talking about, additionally creating, looking for some of these contents to print out, help facilitate a productive conversation, identify gaps in their awareness of resources or conditions or treatment interventions, because stellate ganglion blockade is not something that we learn about in med school. It is a very new treatment intervention. If you asked a standard, primary care doc about it, they would likely say, "Huh? What? Hyperbaric oxygen for TBI, PTSD? Huh? What?" Really, there's a lot of opportunities to educate the primary care providers about what's available. And if you don't know about it already, then reaching out to some of these nonprofits like SOF and like Task Force Dagger Foundation and like Hunter 7, they will put opportunities for treatment and intervention in front of you, regardless of whether it's for you as the operator or your spouse as the family member, or someone in the professional network as a peer. They will help you facilitate a more productive conversation.
Mm-hmm.
Over.
Yeah, so also on the low-hanging fruit, what can be done early on? If testosterone is low, testosterone replacement therapy. If alcohol is being used in a way to deal with stress, to try to get sleep, to try to manage emotions, stop. I mean, it's hard to do, but it is remarkable how much better people's brains work when they're not putting alcohol on top of a damaged brain, right? So we see this all the time, that the guys that have come through our program, and this is a day treatment program, so they can drink at night if they want to. The ones that don't, they're on fire. They're doing great in just a handful of days because they are clearing their body, and their body doesn't have to deal with the alcohol absorption, the metabolism of that, etc. Last thing is medications and alcohol don't work very well together. They never have. So psychiatric medications and alcohol, terrible combination. And psychotherapy is so weak that it's soluble in alcohol. So why do psychotherapy if you're drinking on top of it? Just take a break, take a holiday. Over.
No, hey, Chris, I'm sorry, you got one more point, Dr. Frueh? Okay. I do want to thank you sort of for, bringing up SGB, but sort of what you mentioned on sort of the program. And so just, my 2 cents have, as of recent year and a half ago, going through NICO here at Walter Reed, I was very fortunate to have gone. It was towards the end of my career as I prepared to retire. And I didn't go only because I was retiring. I was going again, as I equated it back to the 2 guys that committed suicide. That was the one time that all of this, if you would, wrapping it up together, made me take a knee. It's the first time I think I ever really asked for help. And I was asking for help for my family first, because I knew I was at a breaking point. And as many of you know, once we put our minds to something, we're going to do it. Right. And so that's just kind of one key point there. And so because of the traumatic brain injuries, a lot of this stuff became evident of what I was going through, what a lot of my peers were going through in my command and in the other commands where I had peer groups in. And I had heard about NICO. And what I'll say about that program and what I'll say about the structure is 2 key points. My docs, of which many of them I've probably had known for 10 to 15 years. So not to name any names, but these guys were our PAs. They knew me. They were taking good care of me and my peers, but they were patching us up and getting us back out the door. Right. So every year they will sign our up waiver or whatever for all the statuses, and we're back out the door and they're taking care of us. They were probably not in that time, not in the right position to look at me holistically, to look at my other friends who were falling apart from operator syndrome, because mechanically, all they did is if I came in with a shoulder problem, they were taking care of the shoulder. If I was coming in with a gut problem, that's what they were taking care of it. And we were just a rotisserie coming in. And most of us didn't want to say there was anything wrong with us because we didn't want to take time off the road. I didn't want to take off time of training, and I just didn't want to sort of appear broken, which is absolutely wrong. But that program, what it did do, and it's just for reference, just the components of Dr. Frueh, as you mentioned, it is looking at us holistically. How I slept, my pain. Again, if stop eating bread and gluten helped me sleep, which then helped me ingest, I don't know how many, thousands of milligrams of B12 they got me on in a hurry because of my brain. I was to a point, like many of us, that I just felt I've become dumber and I'm about to become useless as I get ready to retire. What kind of meaningful work am I going to have after being this special operator for 20 years? And I can barely remember how to speak English or Spanish, just to kind of get you. But that model was so key. It incorporated, blood work, sleep, yoga, art therapy, talk therapy. I will tell you that the talk therapy that I started as I retired, I'm still doing it today, a year and a half later. I am still working on operator syndrome till today with sleep, talk therapy, and I'm on my 4th SGB. And then here in the next 6 months, I'm going to go again because I'm still chipping away at least 22 years in special operations. So it's part of my get well plan. I'll take a second. Somebody was jumping in.
Well, good on you for that, Eric. Good on you for taking care of yourself. I wasn't sure if you had somebody teed up for a question, or can I just make one other comment about stellate? No, almost nobody's heard of stellate ganglion block therapy. And I was just kind of seeing this in the chat. I mean, Bryan, you say primary care physicians don't know about it. Psychologists certainly don't. Psychiatrists, for the most part, don't. And here's the weird thing: it's been around for 100 years. They've been doing stellate ganglion block treatments since the 1920s, and we know it's a very safe, very effective procedure for certain things. What we didn't know until about a decade ago, thanks largely to a couple of pioneers at one of the tier 1 Army SF programs, is that it helps alleviate anxiety and PTSD symptoms. And it has an immediate effect. Like, it's a 20-minute procedure, and you walk out of the room, you walk out of the office going, wow, holy cow. It's almost, it's the closest thing we have to, being in a revivalist tent and getting that healing touch put on you. And it doesn't last forever. I mean, I think that's an important thing, but that doesn't mean it's a failure. That's the other thing I hear, is that people will say, oh, well, it only lasts for 2 to 6 months, so it's not even worth trying. Wow, 2 to 6 months of having no headaches and no anxiety, that's bang for the buck. And yeah, it starts to fade after a while, but so what? You can go back and you can get another one, and it creates that space to engage in the other kind of treatments and the therapies and the other things that are recommended. Eric, I don't know if I just put it on to you. Do you have could you say maybe a few words about your experience after your first stellate ganglion block treatment?
Absolutely. And I want to thank, absolutely. Well, Chris, I want to thank Vic. You're absolutely right. It's died by suicide. And I try to catch myself with that all the time until someone expressed that to me, and I had to check myself, because I was just it was so hard for me to even say that word and even how they did it. But you're absolutely right. It's died by suicide. And I appreciate that it was the ability to correct myself. And so, Chris, to your question, the first one was literally days after my friends died by suicide. I had another friend that had been in the unit that had really bad TBIs. Actually, he's like on his second Purple Heart just from that. He had talked about it because one of the leading doctors doing it used to use this as guinea pigs about 10 years ago. So I'm like, I need this treatment, whatever it is. I know that there's a couple of operators that are better now because of it. So that was my first one. That was kind of almost like an emergency. So that was the first one that I did right in September or October of 2019. And then when I went to NICO, right on that April timeframe, I was starting my healing process, right? Because NICO, as I mentioned, it took me apart literally. It was 18 doctors or whatever they were looking at every aspect of me and all my history for 29 years. And they were starting to work on me. And they're like, hey, would you do acupuncture? And so I ended up getting the Hoffman cocktail. Our old SF medics used to do that to us all the time. I finally got to meet the guy that taught them to do it. And during that process, my therapist is like, hey, you are going through these gates backwards. And what does that mean? That was then my second one. So literally 6 months later, I walked across the street from NICO, went into Walter Reed, and got my second one. That actually helped me continue my healing process. And what do I mean? I quickly shoved about 23 years in SOF into little Pandora's boxes. Every deployment was a little box filled with injuries from moral, physical, time away from family, everything. And I would come back to the team room, to my travel voucher, put that deployment in a little envelope and put it in the safe, and I was back out the door. And for me, what that SGB did is allow me to open up and feel and listen to the therapist and release emotion. I'm going to tell you, I cried. It was just this release, not only physically, as if I took off a rucksack that I had been wearing for a long time, but it allowed me to think clearer, feel the emotions. And with talk therapy, that was really important. At that point, I was, whatever was top concerning me is what I was able to deal with. And as of recent, so now a year into retirement, I'm still shedding away and processing those Pandora boxes, and in particular more with my family, because now I do this therapy with my family. And one key thing, Chris, that's been powerful is my wife got to sit there with me in this procedure, right? I don't know if this is going to be able to work for everybody, but if you get an opportunity and it works for you as a family to sit there, and my wife saw the procedure and just saw me just cry, and the room was quiet, and then I was able to work through it. That's been the power of that SGB. It isn't, as you mentioned, isn't a solution. I slept really good, but I can see my progress getting better. I can see cognitively I'm stronger, right? And I've mentioned this before. I think individuals who at some point identify, I have operator syndrome, just like I have a bad knee or a bad back, as many operators do, and we work towards healing, that's going to be one hell of a powerful person who's able to come back and grow from PTS and this syndrome. So you become a better person. Hopefully that answers your question, Chris. And if there's no comments on that before Lindsay sends me the digital, let me get on to the next piece of here. Okay, so a key challenge for service members seeking help is we don't want to take a break from deploying and being off the mission. This makes it hard to find time to get ahead when challenges start to pop up. It also makes it hard to notice some of them. Health comes second, and often family comes second. I would say that family, we barely even think about that, unfortunately. So what I'm going to ask is, Dr. Fowler, have you experienced this in your work with special operators, the points that I just referenced?
Yeah, so this is, usually we're seeing guys that have now retired and they're trying to find their footing in a new world. They're dealing with what we call loss of logo, right? They were a SEAL, they were a Ranger, etc. And now they're like, well, who am I now, right? So then we're backtracking. We're working kind of backwards to find out, okay, this is Chris's earlier point. What is your new mission? What should your new mission be? Who do you want on your team? Can you reconfigure your team from your guys to your kids, your wife, etc., right? And that is oftentimes the real starting point for them. Whatever treatments we're talking about, we're also talking about the existential crisis of my identity as an operator is changing, right? And I think they'll always think of themselves as operators because that's in fact who they are. But how they can then transfer all of that capacity, the grit, the determination, the drive, and move it into a new mission is usually one of the things that really helps them kind of feel remoralized. And I can't tell you how important it is for anyone, whether they're operators or just regular people who lose something about their identity, is can they find a new way of going at things? Over.
Thank you. That was perfect. Definitely the identity, that's key. And then again, if you're thinking you're coming out of this and it's not the right way, you think you're coming out of it broken, then do you just abandon all of that? And I think we need to have operators and their family come out of the service and continue to still have that in their DNA. And if they choose to take that onto their next career or go freaking, underwater basket weaving, and that's what they want to do, at least they feel, as a whole. And again, in their new mission. And thanks for all the comments that are coming in. So I've got one last piece here, and then I think we're gonna start preparing to wrap this up. This pops up a problem in many of the topics we work with in military special operations family collaborative. It's going to be open to the audience, and I'm going to invite for full participation. What can we do to broaden how we, SOF operators, the community, think of our purpose and our value in special operations? And I'll leave that. That's true, Jeff. Oh, we're opening it up.
Eric, I don't know if it was just my end, but I missed like 10 seconds of the last question you just asked. So could you rephrase? Could you say it again, please? Repeat your last.
Okay. Yep, no problem. So what can we do to broaden how we, special operators, think of our purpose and our value in special operations.
Mm.
And I would also include sort of the family as part of us, our identity.
I think, yeah, as a starting point, but I'm definitely not the right person to make the best comment here. Jeff Darty, if you're there, by all means, chime in after me here. Contributing to the mission. So maybe broadening up to what does it mean to contribute to the mission, and who helps me contribute to the mission. So defining what contributing to the mission means, not necessarily executing it or the mission itself being the primary thing. It is, how do I contribute to the mission? And if that's supporting the people around me, my current group, whoever that's defined by, or supporting those who enable me to directly support the mission. So indirect support of the mission. How do I support the mission? And maybe that's building up my family and focusing on my family right now, because they enable me to later go do the mission. It's a very kind of almost esoteric and broad, 50,000 foot picture of it. But if we just define it as how, the key question being, how do I support the mission? Then that allows you to refocus on, okay, direct and indirect support, and who helps me contribute to the mission success. Over.
Well, and I think to chime in a second, Richard in the chat earlier said something I thought was really insightful. He said, operators become who they are and not just what they do. And I think that's pretty insightful of the type of unique mission focused environment special operations is. And it's almost like after a while you're so focused on the mission and doing right that you don't even realize that's what you're doing anymore. You really do become that. And it's a unique challenge to broaden that and maybe even think about what you're doing besides just accomplishing the mission. Like, are you a leader? Are you raising the next generation to be effective in special operations? Are you a father, and are you modeling that for the guys on your team? Because that has implications for transition. And those are kind of thoughts that came into my mind looking at Richard's comment. That was a really great comment in the chat.
For me, I try to take it back to mission and purpose. Purpose and meaning. What is your meaning in life? And for all of us, for most of us, that's probably multifactorial. It's not just one thing. If it's just one thing, we probably have a problem. But at the point of transitioning out of the service, that's a point where a lifetime's worth of work is now over. And it's time to start a new chapter, essentially. But what is that new chapter? So helping people figure out what their mission and purpose is, I think becomes part of that transition, a critical part of that transition process.
Thanks, Chris. That's a good point. Yeah, we had Mark actually make good comments. Mark, you want to go ahead and articulate your comment there?
Yeah, so I just wanted to bring up the fact that, dealing with former operators, I was formerly at a special missions unit for the Navy, running their HP program, and I still communicate with the guys to this day. Well, a lot of the problem is transitioning to that civilian world, and the sense of urgency is not there in the corporate sector, and their so-called teammates really aren't teammates, not willing participants. And that is a very frustrating thing for them. And it's hard for them because they're trying to adjust and reframe their identity, and it makes it difficult. Over.
I hear that all the time, Mark. That's a really good point. And I think when I try to understand that for myself, because I've never been in the military, but what it comes down to for me is when you're in the military and you're on a mission, you're all focused together on an objective, and it's usually life or death. and maybe some people aren't going to come home. So you know the critical nature of what you're trying to do, and you're all working together. When you go to a civilian workplace, it's kind of every man for himself, every woman for herself. People are there working on a shared mission, yes, but there's internal competition to see who's going to get promoted, who's going to get the credit, who's going to go get some other, next level job at some other organization. So people aren't truly necessarily functioning as a team, and that is a challenge. I don't know what to do about it. We're not going to change civilian culture, unfortunately. But I try to, in my conversations, I try to help guys and gals see that and accept that that's just the way it is, and that they're not crazy. It really is that way. They're not misperceiving something.
So you hit a good piece there, Chris and Mark. Thanks for that question. I think one key thing that was said is I'm thinking about it in the scope of operator syndrome, and a guy who gets out or is transitioning gets out, and he's looking at sort of the menu of what's defined in operator syndrome and whatever that individual thinks, and for many of us, if you talk into a company or you come in and, TBIs and lack of sleep, okay, most people kind of have that, except the TBI, if you would, but it kind of equated to concussions. But then we get this whole stigma about post-traumatic stress, right? And I think that's one thing that I've kind of, it's easy to talk about everything else and maybe how it can affect, but how do you guys see, and in particular, just for time, and then we'll give it back to Lindsay to close out. But I think a big one from a person, right, is being viewed to have this disorder, which many of us, and I think yourselves, were kind of dropping that disorder word just for post-traumatic stuff, and how we're viewed by having that, and how can that actually then affect our identity?
Well, we've got the narrative in society, U.S. society, probably other societies maybe. The veterans are broken. I get asked this question all the time by potential employers. Hey, if I hire a veteran, are they going to snap on the job and hurt somebody? And it's just like, no, they're more likely to be the people that protect everybody else from being hurt if there is an event or an incident. But part of the challenge of transition, I think this has become something else that we forget, or maybe we don't really think about much. But Erick, you found this, and those of you who have transitioned know this. How much new learning is involved in transitioning to civilian society? You've got to learn new customs. You've got to learn maybe even how to dress, how to talk, how to comport yourself in a different work environment. You may have to learn new skills, new family roles. I mean, your role at home and in the family is different. So a lot of new things to learn. And what do we know about TBI and learning? TBI makes it very difficult to learn new materials. So you're starting off with a physiological handicap at the start of your transition.
No, those are great points. And actually, we've got a couple of really good things here. Lauren, some really good comments in here. Actually, so Lainey, hopefully I pronounced your name right. Go ahead.
Yeah, so going back to connecting what Dr. Frueh just said with a minute ago about the transition into the workplace and not being on the team, it really reminds me of some conversations that we've had with wives about not being able to connect with civilian wives once they move away from base. And just feeling like nobody can quite understand me after the history that I've had and what I've been through. And for me, as a clinical mental health counseling student, I kind of see that as a result of small traumas that are that we deal with just in this lifestyle that we totally chalk up to, well, that's just part of the job. That's just part of this culture, But yeah, so just something that the wives also definitely experience in a different way.
Thank you. That's a really good point. I think what was kind of also said, which is that time to transition. I mean, on a personal basis, a year and a half out, I'm still transitioning. Again, there's all of these boxes, just like that proverbial PCS move, right? You move from one base to the other, and how many of you did not just still have boxes you never unpacked, and then you went off to the next PCS move, and then you get there and you still have the little label that told you that that was the box from 2 bases ago. Well, it's the same thing when we transitioned, and someone had made a comment about some of these programs to help transition. I think those are excellent because that kind of, to Chris's point, that's helping you learn how to talk, how to walk. A lot of guys, it's giving the girls, it's giving them sort of that motivation. You're also bringing them into new tribes of other operators and families that are transitioning. But as a family, as a nexus, I mean, there's sometimes that I don't know in this family, sometimes something comes up and now we're working on it, right? And this can be a year out. We're still trying to learn to be a family that's not driven and motivated by that soft blood, right? Like that Kool-Aid, if we would. And now we're civilians, we're trying to find purpose. We've got kids growing up, we've got marital relationship things that took a hold, or at least in this household, for 18 years. I'm unpacking 18 years in 1 year, and God knows what sometimes can trigger something. Usually we're going forward good because we've had some good tools put in our toolbox. And then I've been able to take care of the health and the mental aspect by staying on therapy and knowing, hey, family in this time comes first, the defense of this country, if you would. Unless there's any question, I think Bryan up there.
I just want to highlight a comment in the chat box. Melanie Freeman, she mentions protective factors or activities that perhaps we should be focusing on and talking about. And I'll use this in a lead into my closing comment here. She brings up helping people start thinking about themselves as more than just an operator, but operating is what they do. And this is your job, not your identity, but helping them have that conversation and thought in a productive manner at selection, like right at the outset. How do you help people with thought patterns or behaviors that are protective in nature at the entrance to the soft career pathway? And as part of what she suggests, talking about that identity and some ways to maintain the idea of what yourself can be like and what family life and contributing to society can look like, even while you're going through the pathway. I love that comment. But Jeff Daugherty and I, we talk a lot about and do training and education on how do we think about this pathway to potential for operator syndrome, these military operational exposures? How do we think about that early in the career? And what should we know so that we can mitigate it as early as possible? And I know that was a question from previous, so I want to close with this comment. Being able to identify the threats to health and performance in the operational environment, and being able to identify what protective lifestyle factors look like and what protective nutritional strategies are and what resources and services you have around you to help you answer those questions early on. Hey, I've had this exposure. What does it mean for me? What should I be looking out for? Hey, I've been doing this, and this is what I've noticed maybe on my wearable, or this is what my family has mentioned early. Is this a problem? What should I be doing about it? And especially when they know that they can go talk to the athletic trainer about it. They can go talk to the dietitian about it. They can go talk to the psychiatrist or the behavioral health team about it. Helping them figure out what an early conversation looks like and what a productive conversation looks like really early on. So what do the check engine lights look like? Jeff referred to the operator manual. Like, what if we had that operator manual for maintenance checks and services? And what would check engine lights look like? And then who is part of my team around me that can help me answer these early productive questions about what I can do? Over.
Chris, were you gonna?
Oh, sorry, Eric. Eric. It's me. I'm thinking about Bryan's check engine lights and all. In this topic in particular, what we can do to broaden the understanding of the mission. Some things we talk a lot about at MSOF are the importance of celebrating at family and at work with operator peers. unit traditions. If they're dying, bring them back or recreate them so they're powerful. Things like this, regular routines, tradition, family tradition, and unit tradition, celebration of things like promotion, retirement. These things are meaningful and they do come into these type of conversations, and especially making sense of transition and service over time.
Yeah, those are great points, Kaylee. And I think the tradition and just culture, and hopefully, and I think we've got some current leadership on the call that hopefully we're getting back, post this GWAT, go sort of mentality and hustle and bustle, that we do get back, at least in the SOF world, to sort of that DNA that made us who we were in the beginning. Not that I think they're straying off of it, but those are solid points. And then just, if leaders also understand, at the team room level, it's great, but the leaders understand, hey, let's check the operators, what did we say, the check engine lights, and we're looking at these guys. But again, as we covered, we're not going to put anybody on the bench. We're going to assess, we're going to assess where they're at. We're going to find it, and we're going to make them better, and we're going to get them back on the road, and it's not going to jeopardize them. I think if we take care of that preventive kind of outlook, I think that's where the power is, and it's just going to continue morale, right? I think with that on time, unless any of the panels of doctors need anything to say, hopefully, Lindsay, you're prepared to close out.
Yes. Well, I just wanted to say thank you to everybody for participating tonight. Such a great discussion going on, both live in the discussion and then also in the chat. Really amazing. Lots of resources that were shared that we will add to that resource page on our blog. And we will send out a link to all the information, the replay, as well as the resource page after this evening. So thank you again for being part of our deep dive. Dr. Frueh, Dr. Fowler, Dr. Stepanenko, thank you so much for your time, expertise, and dedication to the special operations community. You're just fantastic resources, always very helpful in getting information out to folks and explaining things in clear ways. If you still have questions, any of our participants that you would like to ask our experts, please submit them via the link that I dropped in the chat. Or you can email our team at home@msofc.org. We'll make sure to get the answers to your questions and include them in the resource page, as I mentioned. And keep an eye out for the further resources posted on our blog as well. The link has a few survey questions for you. We love your feedback. We do actually change our events and the way that we run things based on feedback from previous events. So please take the time to answer those 7 questions for us. And we would like to just improve these events going forward based on your feedback. They're supposed to be responsive to the needs of the community for sure. And then please mark your calendars for our next SOF team room, which is scheduled for August 11th, where we'll take on high performance. And the SOF Health Sprint will follow on this health deep dive to cover traumatic brain injury. So we'll be talking about that a little bit more in depth. Stay tuned for more information there. And you can always reach out to our team either via email or any of our social media with your questions, thoughts, and concerns. Otherwise, thank you very much. Have a fantastic evening.